Hello, Dr. Debbie Morris here for the third lecture in the spring neurology course. And today we're going to be talking about an important class of neurologic conditions resulting from closed head injuries. We'll talk a little bit about other head injuries, but primarily we're going to be discussing what we call closed head injuries. And we're going to talk about the mechanisms, the types, and the consequences. And we'll need to remember things from the first and second lectures at the anatomy and the exam as we talk about these issues. So we're going to be covering these topics and talking about assessment and a little bit about treatment. So head injuries are important because traumatic brain injury is the leading cause of death and disability in children and adults, young adults. It also has a huge impact on older adults because they are more prone to falls and tend to have a higher degree of morbidity and mortality related to head injuries. We see head injuries in children quite commonly in acute care settings and primary care settings. So the ER, the urgent care, the pediatrician's office. And just recognizing that most of the deaths that occurred due to traumatic injury are related to that head injury component of those traumatic injuries. The most common cause of brain injury, of head injury, are motor vehicle accidents. Falls are close second. There are a large number of head injuries that are related to sports and recreation, some sports more than others. And this obviously tends to occur more in younger people who are participating in sports like soccer and football. Assaults and firearm-related injuries are an important cause of brain injury. And then child abuse, or what we call NAT, non-accidental trauma in children. Non-accidental trauma in children occurs most frequently in very young children, from infancy to the age of about 4. And non-accidental trauma, which is child abuse, is the leading cause of death for head injuries in children under 2. We'll talk a lot about the different degrees of head injury, but minor head injuries, which are extremely common, are head injuries that are defined as occurring in folks who have a normal mental status examination at their initial exam and who have no abnormal findings or focal findings on neurologic exam, including the fundoscopic exam. So focal findings would be suggestions of specific injury to, say, the motor cortex or the sensory cortex, and who have no physical evidence of a skull fracture. We spoke about the Glasgow Coma Scale in our last lecture, and I just wanted to remind you that this is a tool that we use to assess head injury based on 3 criteria: whether the person opens their eyes, what their best verbal response is, and what their best motor response is. And here we have in the scale on the left, someone who opens their eyes spontaneously gets a 4. Someone who you can't get to open their eyes gets a 1. Somebody who is oriented gets a 5 on verbal response. Somebody who obeys commands to move, gets a 6 on motor response. And the definition when we use the Glasgow Coma Scale for mild head injury is a score from 13 to 15. Some people say 14 to 15, moderate 9 to 12, and severe 3 to 8. And do remember that those folks who have very low GCSs, 3 to 4, who are comatose, have an extremely high likelihood of dying or ending up in a persistent vegetative state. When a head injury first occurs, the initial damage resulting from the trauma is classified as the primary brain injury. And there are all kinds of primary injuries, bruises and lacerations, blood vessel damage, and foreign object penetration. There are also specific primary brain injuries that result from acceleration forces and deceleration forces and shearing forces. After the initial injury to the brain, there are secondary effects with the release of intracellular substances, neurotransmitters, inflammatory substances, and of course bleeding, and all of the subsequent effects that result from the primary brain injury, and often can result in a good deal of additional damage, edema, for instance. And one of our goals is to try to mitigate and prevent as much secondary brain injury as possible, recognizing that the primary injury is likely to lead to secondary injury. One of the big issues with secondary injury is that you can have increases in intracranial pressure. So those ruptured blood vessels resulting in bleeding cause a mass effect. There is limited space in the skull, and we can end up with massively increased intracranial pressure. There is, as I said, a limited amount of space in the skull. It is occupied by the brain and the cerebrospinal fluid and the blood that is flowing through the brain. And the pressure in there is normally kept very stable, and there is a limited ability to compensate. So if there is an increase in pressure from bleeding, you will make less CSF, you might get a little bit less blood flow. Unfortunately, ultimately, you can't continue to compensate. And as intracerebral pressure goes up, the perfusion pressure, cerebral perfusion pressure, CPP, will go down. And cerebral perfusion pressure is a figure that is basically mean arterial pressure, which we've talked about in cardiology, minus intracranial pressure. And it's important to keep cerebral perfusion pressure adequate to perfuse the brain and prevent secondary ischemic issues. One of the things that happens when intracranial pressure goes up is that there is a set of reflexes called Cushing's reflex, resulting in hypertension, bradycardia, and respiratory irregularities. So this is something to pay close attention to in a patient who you are assessing for brain injury or for head injury. Somebody who has hypertension and bradycardia likely has elevated intracranial pressure, and this is an emergency. This is not a closed head injury. This is a scalp injury, but it's important to talk about it here. And I think it's probably something you've talked about in emergency medicine. It's very common to have isolated scalp trauma, and this is a minor head injury if there is no associated additional injury. And it by itself can be an emergency because when large areas of the scalp are avulsed or peeled back, you can have extremely rapid bleeding. And controlling that bleeding and in some cases replacing blood are life-saving measures. It is possible to die of blood loss from a scalp injury. When a scalp injury is associated with a skull fracture, we have a much more serious injury than either of those by itself, and that would be called an open skull fracture. So scalp injuries are just something to be aware of as requiring attention and control. So let's talk a little bit about skull fractures. I came across two different sets of, quote, types of skull fractures, one which had 4 and one which had 6. I took the last 2 off of this because they weren't particularly helpful, and we will be talking about 3 of these 4. So linear skull fractures, depressed skull fractures, diastatic skull fractures, which are fractures that occur along suture lines and are much more common in children, and then basal or basilar skull fractures. So a linear skull fracture is exactly what it sounds like, and if you look here, you can see a number of abnormalities, but most particularly here we have a linear skull fracture. They can be simple or they can be comminuted. There can be fragmentation of the bone. And when that happens, you can have bone fragments that penetrate the brain tissue, although that's more common in a depressed skull fracture that we'll talk about next. Again, when you have a linear skull fracture or any skull fracture combined with a scalp laceration, you would call that an open fracture or a compound fracture. And we become a lot more concerned about the potential for CNS infection, for instance, and the requirement for antibiotic prophylaxis. Depressed skull fractures also may be seen with or without scalp injury, and they're exactly what they sound like. That part of the skull that is fractured has been pushed in and is impinging on the brain. These often require surgical intervention, particularly if the depression is greater than the thickness of the skull. Brain imaging is also important to make sure that there are no associated bleeds or other injuries that may require surgical intervention. And then basal skull fractures or basilar skull fractures. So basilar skull fractures tend to occur along with other serious intracranial injuries because the skull at the mastoid and the posterior temporal bone and occipital bones tends to be thicker, and it requires significant force to cause these fractures. So again, additional intracranial injury is often associated. The other issue with basal skull fractures is that they often cause tearing of the dura, which results in leaking of spinal fluid from the ear or from the nose, if the sphenoid or ethmoid bones have been affected. So a bloody or clear discharge from the ears or the nose should be assessed to see if it's CSF. Again, I'm sure you talked about basal skull fractures in emergency medicine. They may be associated, as I said, with these CSF leaks. They may be associated with raccoon eyes, with battle sign, which is bruising over the mastoid bone behind the ear, with blood behind the tympanic membrane or hemotympanum, with seventh cranial nerve palsies like a Bell-type palsy, with vertigo or hearing issues that are acute, resulting from eighth nerve problems. And one of the things to be aware of is that the bleeding that results in raccoon eyes and battle sign, it tends to be slow. So you hopefully will have recognized the potential for this fracture and done an assessment before you actually see the bruising, because it takes a day or even sometimes more, up to 3 days, to get the full picture with the battle sign, which you see here on the left, the raccoon eyes, which we see in the middle, and hemotympanum, which we see on the right, along with a bloody discharge on the sheets that has sort of resulted in rings where the CSF has traveled further in the sheet than the blood, which is fairly typical of bloody CSF. So those are the skull fractures that we are covering today. And I want to move on to what we often call concussion, or mild traumatic brain injury, or MTBI. This is the most common injury that you are likely to see as a result of head trauma. It is defined as an impairment of brain function that's caused by trauma without any detectable mass lesions or bleeding or fractures or other gross lesions. And it is minor brain function impairment. So these people tend to come in with a GCS that is close to normal, 14 to 15. And 80% of traumatic brain injuries are mild, are concussion, mild TBI. The moderate class would have a GCS of 9 to 13. As I said earlier, severe traumatic brain injury, the GCS is 3 to 8, and the incidence of death is higher. We see a lot more traumatic brain injury in males than in females, and there are peaks in the incidence. So they are common in very young children, 0 to 4, in adolescents and young adults. It's actually trimodal if I said bimodal. And then in the elderly. And the mortality is high in the elderly because, and we'll talk a little bit about why that is later. Mild traumatic brain injury was an extremely common injury in the wars in Iraq and Afghanistan, where people were, soldiers were exposed to IEDs and nearby explosions, and had, while often mild traumatic brain injury, sometimes long-standing symptoms, because some folks with mild traumatic brain injury end up with something called post-concussion syndrome. So typically, the brain dysfunction associated with MTBI is just transient confusion, maybe a little bit of memory impairment. I don't remember what happened right at the moment before I got hit. Headache, fatigue, irritability, maybe a little dizziness, maybe nausea and vomiting, but typically not intractable nausea and vomiting. Blurred vision without obvious double vision or focal visual disturbances, and along with the dizziness, some balance issues. And again, it would be these symptoms without any evidence of bleeding, of fracture, of more serious injury. As I mentioned, some folks with concussion with MTBI will have persistent symptoms that may not be immediately apparent, but become more apparent days to weeks after the injury. And how they present at the time of the injury doesn't predict the occurrence of post-concussion syndrome. So somebody who is more symptomatic in the hours immediately after the injury is not more likely to develop post-concussion syndrome than somebody who is mildly symptomatic. This condition also can co-occur with post-traumatic stress disorder. It occurs after traumatic incidents, things like car accidents, things like falls, things like assaults, and PTSD can also sometimes cause some fairly similar symptoms. So it's important that these people be assessed appropriately with neuropsychological testing, and that they are treated for their symptoms, that their symptoms are acknowledged, and that they are followed. So how do we assess MTBI? Well, everything that we've taught you about doing an assessment, you have to take a good history. It's really important to know what happened. How did this trauma occur? What was the mechanism of the injury? With a little bit of extra attention around what your patient remembers of the events around the injury, whether they lost consciousness, which is witnessed or not, whether they are having nausea, vomiting, visual disturbances, headache, dizziness, imbalance, all those things that we talked about. And then you want to do a good neurological assessment, a good neuro exam, including some mental status assessment. It doesn't have to be formal, but making sure that they're alert and oriented. Maybe a little bit assessing memory. You do a good cranial nerve exam, and that becomes extra important, because brain injury resulting in edema or mass lesions can impact those cranial nerve nuclei and cranial nerve roots and cause focal findings in the neurological exam to alert you to the need to do more of an assessment and do imaging. Certainly, it's very important to do a good fundoscopic exam, and then some screening sensory, motor, and reflex exam. Make sure that sensation is largely intact, that their motor strength is normal and symmetric, and that their reflexes are normal and symmetric. And coordination testing, things like your rapid alternating movement and finger to nose test. We'll talk a little bit as we move forward about when to image, but if there is reason to image, we image. And in most cases, in the acute setting, that is going to be with a non-contrast head CT. Readily available, very quick, so not something where you're sticking the person in a tube where it's hard to get to them. Not terribly expensive. So you do that if it's needed. And then in terms of treatment, you want to make sure that they rest, and it is fine for people with mild TBI to go to sleep. You do want them to be with somebody so that they can be observed, and you want to be sure to schedule appropriate near interval follow-up to make sure that their symptoms aren't progressing and that hopefully they are resolving. It is very important to avoid further potential injury. Putting somebody back into play when they have not recovered from MTBI, from mild traumatic brain injury, puts them at much higher risk of developing post-concussive syndrome and long-term neurologic symptoms. One of the mechanisms of injury that occurs during trauma is something called diffuse axonal injury. This is often a result of sudden deceleration. So car wrecks, particularly, the car hitting something and stopping suddenly, results in shearing forces in the brain that injure axons in the white matter and can result in microhemorrhages within the brain as opposed to major bleeds, hematomas. And it often results in coma that may last hours or longer, so persistent loss of consciousness, and is frequently associated with permanent deficits because the axonal axonal injuries are not necessarily going to be able to heal and reestablish the connections. They are frequently associated on imaging with microhemorrhages. And here is an initial CT scan that shows some swelling, some punctated hemorrhages along the white-gray cerebral cortex junction. You don't, this is a pretty nonspecific image, and it is not something that you necessarily see in the initial scan. I want to move on to the types of hemorrhage in the brain that are typically resulting from trauma. So we're going to talk about intracranial hematomas. And the three that we're going to talk about, I'm going to skip subarachnoid hematoma here because subarachnoid hematoma or hemorrhage is not typically associated with trauma. It has other causes. But the types of brain hemorrhage that are typically caused by trauma include epidural hematomas, subdural hematomas, and intracerebral hemorrhage or contusion or bruising. And here we have just an image showing those three types of hemorrhage by their location, along with the subarachnoid hemorrhage. So let's talk about what they are and what distinguishes them. The first one that we're going to talk about is epidural hematoma. Epidural hematoma is a collection of blood between the dura mater and the skull. It is very highly associated with skull fracture and often occurs in the temporal parietal area of the skull. Because of its location between the skull and the dura, you tend to get a biconvex, like lens shape, sometimes described as a football shape, kind of fusiform here, convex lens, biconvex lens. And it occurs when the meningeal vessels, and most particularly the middle meningeal artery, get torn often again with a skull fracture. The hematoma, the collection of blood, impinges on the adjacent brain. So brain is getting flattened or displaced. It has a mass effect, so it's filling up space inside that limited space in the skull, which causes an increase in intracranial pressure. It's common for people with epidural hematomas to have a loss of consciousness, often a brief loss of consciousness, then to become lucid and have a lucid period, which is not something that always happens, but may happen. And then as the hematoma grows and the intracranial pressures increase, they'll deteriorate rapidly. And that deterioration can result in brain herniation. And we'll talk about the different kinds of brain herniation a little bit later in this lecture. In this image, you can see again this biconvex, sort of lens-shaped or football-shaped area of bleeding. They got hit on the head, and they've also got a knot on their head, and they may or may not have a skull fracture. This isn't the optimal image to see that. These folks require emergency treatment. That hematoma has to be removed, so surgical decompression, have to open the skull, get the blood out. The next we want to talk about are subdural hematomas. Subdural hematomas occur between the dura mater and the arachnoid mater, so not between the skull and the dura. They can look somewhat similar in shape, but more often are sort of arc-shaped or following along the skull. And they are caused by tears in those dural veins that bridge the subdural space on the way taking venous blood from the brain to those venous sinuses that are within the dura. They also may be associated with a skull fracture. Epidural hemorrhages are always acute, but subdural hematomas have sort of three patterns. There are acute subdural hematomas that occur within hours of the injury, subacute hematomas that present within days, a day, 6 days of the injury, and chronic subdural hematomas, which don't become apparent until days to weeks after the injury. The bleeding can be very slow. One of the interesting things about subdural hematomas is that they are more common in older people and chronic alcoholics. And the reason for that is that they the brain tends to be atrophied. There's a little bit more space. There's more kind of potential for the forces that cause the injury to result in tearing of those bridging veins. Little kids are also at higher risk. And here, this is a more typical shape for a subdural hematoma with that kind of arc-shaped bleed that follows along the skull outside of the brain. Subdural hematomas are common with sudden acceleration deceleration injuries where the head is perhaps suddenly moved forward by a sudden stop and then decelerates. And we one of the things that we notice with subdural hematomas is that these lesions, these crescent-shaped lesions, cross suture lines, which is not true of epidural hematomas. They tend to be restricted by suture lines. You can get a subdural hematoma just from a fall at ground level. You don't necessarily need a kind of more obvious trauma. And this is something to pay attention to in older people. And one of the reasons we ask older people if they've had a fall, and anybody who's older who is presenting with confusion or any neurological symptoms, it's important to find out whether they've had a fall. The reason these bleeds can be subacute or chronic is that the bleeding is slower because it's venous bleeding as opposed to the arterial bleeding of epidural hematomas. They grow faster. You may or may not see subacute subdurals on imaging. We usually on initial imaging, and remember that initial imaging is a non-contrast head CT. So if you suspect a subdural hematoma, you might want to add IV contrast to your CT or get an MRI. And over time, the appearance of chronic subdural hematomas is not light on the image, but dark because of the metabolism that's occurring in that blood in the hematoma. So subacute subdural hematomas can appear isodense. That's why they're hard to see on a non-contrast CT. Again, you may need to get additional imaging on those folks. Chronic subdural hematomas, which are hematomas that become apparent 2 weeks after the initial injury, appear dark or hypodense on a non-contrast CT. And in this next chart, we are just showing some of the differences between epidural and subdural lesions along with brain contusions, which I don't have a separate slide for. So epidurals are between the skull and the dura. They tend to be biconvex, football shaped. They often occur with a skull fracture, and they are arterial bleeds. Subdurals are between the dura mater and the arachnoid. They tend to be crescent shaped and are common with acceleration deceleration injuries and tears of bridging veins, and can result from ground level falls, particularly in the elderly, and are common in elderly folks and chronic alcoholics because of the brain atrophy. And then contusions are usually anterior temporal or posterior frontal lobes, and they may not be apparent on initial CT because the bleeding can be slow and delayed. They can be caused by severe trauma. They are a characteristic of shaken baby syndrome, as is diffuse axonal injury, which can occur with shaken baby syndrome. So let's move on to a consequence of these potential traumatic injuries that result in a mass effect and increased intracranial pressure, and talk about brain herniation. This says cerebral herniation, but not all brain herniations are of the cerebrum. So I'm gonna almost change the slide, but I waffled and ended up leaving it. But what is a herniation? So sometimes normal brain gets pushed, displaced to a place it's not supposed to be because of increased pressure from a mass effect. And that can be from a traumatic event causing a mass, like a hematoma, subdural or epidural, or it can be from a tumor, or it can be from edema after ischemia, or it can be from an infectious process that's increasing intracranial pressure, things like meningitis. And there are different types of brain herniations. This is not all of them, but we'll talk. These are the ones that I think it's most important for you to be familiar with. The places that brain gets displaced tend to be places where there is restriction to brain movement, which includes those dural reflections that we talked about that stabilize the brain, so the falx cerebri and the tentorium. Also the foramen magnum. These are places where brain movement is restricted, but with extra pressure, part of the brain can get pushed and impinged and pushed into or through a spot, which results in dysfunction. So cingulate gyrus herniation is when the innermost part of the frontal lobe gets shoved under the falx cerebri. So remember, the falx is this leathery extension of dura between the hemispheres, and it happens typically when one of the hemispheres of the cerebrum is subjected to pressure from either swelling edema or from a mass effect, and it pushes this gyrus. The gyri, remember, are the mountains, not the valleys, and it pushes the cingulate gyrus under the falx cerebri. It may occur with other types of herniation because the same increase in pressure or mass effect that caused that herniation may cause an uncal herniation or a central herniation. Uncal herniations are the most common herniations, and they occur when the uncus is pushed under the tentorium cerebellum and often causes compression of the third cranial nerve, resulting in parasympathetic symptoms, because remember that the third cranial nerve is part of the brainstem. It has motor effects on the pupil and other parts of the eye, and so it can result in an ipsilateral fixed and dilated pupil. The pyramidal tracts that help to control motor function can result in contralateral motor paralysis. So the fixed pupil is the same side, ipsilateral, and the motor dysfunction is contralateral. Central herniation is more common with midline lesions. And here we have cerebrum being pushed down between the tentoria, and it tends to cause not dilated pupils, but constricted pupils, increased muscle tone, positive Babinski. This is not in walkie-talkie patients. These are patients who are comatose, and they often have abnormal breathing patterns, including hyperventilation and decorticate posturing. And we talked about decorticate and decerebrate posturing in the neuro exam lecture, so you might want to go back and review that. Tonsillar herniation occurs when what are called the tonsils of the cerebellum get pushed down through the foramen magnum, and this can result in sudden flaccid paralysis and sudden death, also with pinpoint pupils. There is a good osmosis video. This is a 15-minute video, so I am not going to play it as part of this lecture, but I would strongly suggest that you go into the PowerPoint and watch this video. I have another one at the end of the lecture, but osmosis does a good job with summarizing things, reviewing things, repeating things in ways that I think will help you remember and learn. Whoops. So, a little bit more about assessing head injuries and intracranial bleeds particularly. So obviously, if we suspect an intracranial bleed, we have to do imaging. And this takes for granted that we're going to handle ABCs. So we make sure that the patient has a protected airway. Obviously, if there are issues with consciousness, we're going to be intubating them. We're going to stabilize them as far as possible. But then we need to look at our current guidelines in our institution and do appropriate imaging. At this point in time, in most institutions, a non-contrast CT is the procedure of choice. But there may be times where we suspect something more subtle, or when we suspect a subacute subdural, we're getting an MRI is more appropriate. Obviously, in addition to our other stabilizing effects, the ABCs, the things that we're going to do to make sure that the patient is stable, we also want to make sure that we don't cause further injury, and therefore if there is a mechanism of injury that suggests the possibility of C-spine injury, we're going to image the C-spine. Now, there are times where it's obvious that we need to image. If somebody is having issues with, if they're unconscious, they need to be imaged. If they are have any focal neurological signs, they need to be imaged. But sometimes it's a little harder to decide, and that's particularly when we're talking about mild traumatic brain injury. So most people with MTBI do not need to be imaged, but we use various decision-making tools and guidelines to determine who does need to be imaged, okay? And these are two sets of criteria. The New Orleans criteria for folks who have a normal Glasgow Coma scale, and the Canadian CT head rule for folks who have a GCS in that MTBI classification. So in the New Orleans criteria, we image folks with headache, with vomiting, who are greater than 60 years old, because you'll remember they're at higher risk for some particular injuries like subdurals. Anybody who's intoxicated, because it's hard to sort out the symptoms of intoxication from the symptoms of head injury. Folks who have persistent retrograde amnesia, who do not remember what happened immediately before the event. Folks who have evidence of trauma of their head above the clavicles, and anybody who has a seizure, even if their GCS was 15. The Canadian rules include more than one episode of vomiting, so we allow people to vomit once. Retrograde amnesia that lasts for 30 minutes or longer. A dangerous mechanism of injury, so a fall from greater than 3 feet. Signs of a basilar skull fracture, and we talked about those a little bit. The raccoon eyes, the battle sign, and so forth. And the American College of Emergency Physicians has their own guidelines. They say that anyone with a GCS of less than 15 at the time of evaluation should have a non-contrast CT. And I think that that's probably very appropriate in a setting where that's available. But again, thinking about the folks who have MTBI with or without the loss of consciousness, if anybody who vomits more than twice, who has a moderate to severe headache, who is older, who has focal neurologic findings, who has a coagulopathy, including therapeutic anticoagulation, and dangerous mechanism of injury, along with the other things that were in those other decision-making criteria. So intoxication, evidence of trauma above the clavicles, persistent retrograde amnesia, and seizure. And this is simply a link to a pocket card that you can print and stick in your pocket for reference if you're working in the ER, although I'm sure that you could also just look at it. But it's a resource that's useful, so I'd suggest you download that. And then management. So obviously we secure the airway and we intubate patients who have decreased level of consciousness, who are not able to protect their airway. If we suspect in elevated intracranial pressure, there are ways to decrease that using diuresis. So mannitol is a diuretic that works by increasing osmolarity and pulling fluid out of cells. So that's a management tool for decreasing intracranial pressure while we figure out what to do next. We want to make sure that we lower blood pressure, but not too far or too abruptly. So we want to get the mean arterial pressure under 130. And once the patient is stable, we get an emergent non-contrast CT scan. It's important to keep the patient euvolemic using isotonic fluids, so 0.9 or lactated ringers, to maintain appropriate perfusion, but not to make the person more likely to develop brain edema. We don't want them to develop fever, and as we figure out what we need to do in terms of operative management, get the patient to the operating room, or if not to the operating room, to the ICU for ongoing support. It's important to pay attention to the fact that there are some things that are associated with a much higher risk of morbidity, so low blood pressure, again, making it important to maintain volume, low oxygenation. These are both associated with about 150% increase in mortality. So we're treating hypertension, but we're also treating hypotension. Certainly we need to give people oxygen if they're hypoxic. We want to make sure that they are ventilating adequately. And in fact, sometimes we hyperventilate people with cerebral edema to try to decrease pressures. And at the time of surgery, people with head injuries and a GCS of less than or equal to 8 may have a monitor inserted to allow ongoing real-time monitoring of their intracerebral pressure so that changes are noticed. The neurosurgeon does that. And again, the skull is a box. It has a specific volume, and the brain takes up the most of that volume. The brain in an adult is about 1,300 ml, and there's usually about 100 to 150 ml of cerebrospinal fluid in the ventricles and surrounding the brain and the spinal cord. There's also blood in the brain at any given time. There's 100 to 150 mLs of blood. So if there's anything that's changing the volume, specifically increasing the volume, compensation is required. So if we have a subdural hematoma that is increasing volume, we're going to make less CSF because we're going to have to decrease that volume. And if we can't decrease the volume, pressure is going to go up. When we have an acute change in intracranial pressure, we develop this Cushing reflex resulting in Cushing's triad. And Cushing's triad is hypertension with a widened pulse pressure, so it tends to be a dramatically increased systolic blood pressure, but without a dramatically increased diastolic blood pressure, and even sometimes a decreased diastolic blood pressure, bradycardia, and irregular respirations. Okay, here's another osmosis video that summarizes quite a bit of the material in this lecture. Again, I'm not going to play it. You might want to watch it. It is focused a lot on what areas in this topic are common exam questions, and we're talking about certifying exam questions. So just something to go over and consider watching. And I hope that you enjoyed this lecture, and there's a list of references here. I checked all the links. I did not update the references, but I didn't make a whole lot of changes in the material. So you don't have to go read Tintinelli's, but I do want you to have reviewed this material in your text and in current concerning the specific topics.